Okay, so today we're going to talk about chapter 5, which is the liver, and we're going to get back to here. Um, so there's a lot in this chapter, so we're going to split it in between 2 weeks so that you have 2 weeks to kind of study the information because, liver being such a big organ, of course, has a lot of anatomy, physiology, pathology that we need to go over. I'm gonna objectives, just learn the normal anatomy, describe different methods to classify the anatomy, various functions of the liver, lab values associated, patient prep, scan techniques, sonographic appearance of the normal liver, discuss the pathophysiology, describe the clinical signs and symptoms of different liver lesions, discuss ultrasound contrast of the liver, and discuss benefits of the elastography of the liver. I'm not going to go over embryology too much, but there is a couple things I just want you to know about it. So when there is a fetus, the umbilical vein in the fetus carries oxygenated blood from the placenta to the fetus, ascends the fetal abdomen, and courses to the liver. A portion of the blood flow is allowed to bypass fetal liver via the ductus venosus. And after birth, both of these veins close and become ligaments. So the umbilical vein becomes ligamentum teres, and the ductus venosus becomes a ligamentum venosum. So those are the two things I want you to know about that. So they close once the baby is born. We don't need it anymore after we're born, and so they become ligaments. The liver occupies the right hypochondrium, greater part of the epigastric region, and extends in varying degrees into the left hypochondrium as far as the mammary line. It's huge, actually, compared to a lot of our other organs. And it does a lot of good stuff for us. And so, yeah, it's very important. The liver can be described as irregular, hemispheric, or wedge shaped, as you can see, and probably what you have learned about in anatomy and physiology. Here is a picture of the liver in relationship to other organs. A couple things that are as important here is like the subhepatic space. So the space below the liver, sometimes fluid can be accumulated there. And the subphrenic state recess is below the diaphragm, that space. Normal sonographic anatomy, you're going to start scanning a liver pretty soon. And so you will be looking at it like this. And this is what your liver looks like when it's healthy. The first picture A is a sagittal image of the right liver lobe with the right kidney there. And as you can see, like the liver is like homogeneous echo pattern. There's you can see little veins and portal veins within the liver there. The B is showing the hepatic veins. The liver is the largest internal organ of the body. It weighs quite a bit. It weighs about 1,200 grams in a woman, 1,600 grams in an adult. And our normal ranges are anterior to posterior, 10 to 12 centimeters, length is 13 to 15.5, and transverse is 20 to 22.5. So I would study those normal measurements there. This is a image of the anatomy of the liver. I won't go through every single thing with this, but I would study this in your book. You do need to know quite a few of the different ligaments within the liver. And you need to know like where they're located, basically. So the coronary ligament connects the posterior superior liver surface to the diaphragm. The falciform ligament is a broad, thin anterior posterior fold of the parietal perineum. It originates from the mid portion of the coronary ligament and inserts itself in the parasagittal plane anteriorly and shifts obliquely to its posterior surface. The ligament teres, which was the umbilical vein when we were a fetus, remember, it ascends from the umbilicus and free margin of the falciform ligament to the notch in the anterior liver border. And the ligament venosum was the ductus venosum in that fetus, and it is usually attached to the left branch of the portal vein. There's a triangular ligament, a gastrohepatic ligament, a hepatoduodenal ligament. And what's important about the hepatoduodenal ligament is it surrounds the portal triad, the portal vein, hepatic artery, and bile duct, which is important for you to know prior to entering the porta hepatis. So I would just know kind of a little bit about what makes each one unique and where they're kind of like located at. The ligament teres here, you can see that it kind of divides the left and the right lobe. And that's kind of its claim to fame right there. Another important thing that we need to look at when we're looking at the anatomy of the liver is the vascular system and how different veins appear in the liver. So portal veins are going courses with branches of the hepatic artery and the bile duct known as the portal triad. The portal triad is covered by Gleason's capsule and is highly reflective, making them hyperechoic. So portal veins have hyperechoic walls. I mean, they're going to have bright walls. By contrast, hepatic veins are surrounded by parenchymal tissue and have rather imperceptible margins. So you won't see that echogenic wall with the hepatic veins. Portal veins branch can be traced back to the main portal vein. Hepatic veins can be traced back to the IVC. Another interesting thing is like the portal veins, they run horizontal in the liver, while the hepatic veins are more sagittal long. And the angles, the apex formed at the communication point superiorly and supremedially toward the IVC. So they're running at different things. Just know that like the portal veins are more horizontal and the hepatic veins run more like long. Hepatic veins are interlobal and intersegmental, coursing between lobes and segments, and portal veins are intrasegmental, coursing within the lobar segments. There's multiple different anatomic divisions for the liver. There's the right lobe, there's the left lobe, there's a caudate lobe and a quadrate lobe. Here it is. Here's the left lobe. That's going to be, you know, a little bit more on the left side of midline. And then the right lobe here, the quadrate lobe is more by the gallbladder, and the caudate lobe is more kind of by the IVC entrance. The sonographic landmarks are used to recognize the lobes and segments. So let's talk about that a little bit. The Queneau's anatomy are 8 functional separate liver segments. And the reason that these are important are that if there's a hepatic mass, this is how the radiologist identifies where the hepatic mass is from the 8 different segments. So the caudate lobe is segment 1. The left lobe makes up segments 2 through 4, and the right lobe makes up segments 5 through 8. The division is based on hepatic veins and portal veins. The hepatic veins provide the boundaries of each segment. So that's how they're kind of broken up, is where the hepatic veins are making the boundaries, kind of like states. And but it allows a major resections up to 75% of the liver tissue, providing 2 or 3 segments remain uncompromised. So it's a way that they can remove or biopsy or resect some of the liver that's not good, while keeping the integrity of the rest of the liver unharmed. Here is what they look like. So these, you can see the hepatic veins here are the one, like the borders, basically. Now, I don't want you to spend too much time on this. I want you to know that there's 8 segments, that they're separated by the hepatic vein, and just like the segment 1 is the caudate lobe, the left lobe makes up segment 2 through 4, and the right lobe makes up segment 5 through 8. But I don't want you to like have to know exactly which segment is where at this time, because that would take a lot of time. And we have so much to do that I don't want you to get focused on this and miss some of the stuff that's just equally as important. There's multiple variations in shape and lobe size, thinning of the left lobe. We're all different, and it's just kind of crazy that, your liver can be different too. I've noticed just different anatomic variations in every person. So liver is no exception. One of the things that's really interesting that I've seen a couple times when I've scanned baby is situs inversus, where everything, it's like a mirror image. So everything is opposite. So instead of the liver predominantly being on the right side, it's going to be predominantly on the left side. It's crazy. That's very rare. One of the ones that I really want you to know is a radial lobe, or Riedel, and is a common variant, giving the impression of hepatomegaly, but it is just a downward projection of the anterior edge of the liver. So there's just an extension. It doesn't necessarily mean that the liver is enlarged, but it's more like a finger-like or tongue-like projection that kind of goes over the kidney. Here's a picture of it. So usually like a liver would stop like mid, or the liver stops around mid kidney around. Um, this liver extends past the kidney. The liver receives dual blood supply. It receives blood from the hepatic arterial blood that's oxygen rich, and it also receives blood from the portal venous blood that's rich after going through the GI tract. The hepatic veins drain in the blood into the IVC. The hepatic arteries are very important. So this is where I really want you to start like zoning in. The hepatic artery lies to the left of the common bile duct, anterior to the portal vein. It turns its cephalid and gives 3 branches: the gastroduodenal artery, the supraduodenal artery, and the right gastric artery. The caudate lobe receives arterial blood from both the right and left branches, and the cystic artery arises off the right branch, and the middle hepatic artery usually arises from the left branch. So this is a sagittal scan of it in D, sagittal scan of the abdominal aorta, the celiac artery coming off there that we talked about earlier or last lecture, and the superior mesenteric artery. So you can see how they're branching off of the aorta there. This is what it looks like in transverse, kind of like that seagull or a birdie. There's the common hepatic artery there. There's a splenic artery coming off of the celiac artery. And then this is an image of kind of the same as E. F is just with color. So you can see how the common hepatic artery is starting to go into the liver. The portal veins, the main portal vein originates to the right of the midline at junction of the splenic vein and superior mesenteric vein. It courses cephalad into the right into the porta hepatis. And the main portal vein usually measures 11 plus or minus 2 millimeters. So a range like 6 to 15. It's really important. We like to image it every single time that we're scanning. And it has usually hepatopetal flow towards the liver. The main portal vein then divides once it gets into the liver into the smaller left portal vein, and to the right of midline, more anterior and cradle into the larger right portal vein, posterior and caudal. The common hepatic, intrahepatic ducts, and portal veins, they usually course parallel to each other. So the portal venous blood and the bile duct flow are in opposite directions. You can see them kind of like a parallel channel sign. So they're both like running right next to each other. Here is an image of the main portal vein, and this is what the image that we like to take, kind of like in a transverse sagittal through the ribs image. But you can see the main portal vein just going in there, and we'll put color on and you'll see it light up red, which is towards the transducer. So that's a hepatopetal flow. Blue is away. And yeah, and then this is a transverse view of the left portal vein, and then it branches. So there's multiple different branches from the main portal vein. O is a normal architecture sagittally of what you're going to see. You're going to see the common bile duct. The hepatic artery runs perpendicular to both of these. So you're going to see it as a little circle, and then the portal vein here. When the bile ducts are enlarged, you're going to see like the main portal vein and the bile, or the portal veins and the bile ducts running right next to each other. The bile ducts are enlarged, and so you can really see like a 2 track through the liver. The hepatic veins are best visualized in a transverse scan in the superior portion of the liver, and they drain directly into the superior aspect of the IVC. So there's the right hepatic vein, the main hepatic vein, and the left hepatic vein. The right hepatic vein is the largest and courses between the anterior and posterior branches of the right portal vein. The main hepatic vein is located in the main lobar fissure, and the left hepatic vein is the smallest hepatic vein. The inferior right hepatic vein is a normal variant, but it can be very difficult to visualize. That's pretty much all I want you to know about that. Here's an image of them. This is what I really want you to see. So the right hepatic vein here, the middle hepatic vein, and the left hepatic vein are seen in a transverse scan draining into the IVC. They have hepatofugal flow, so they're flowing away from the liver. So you can see that their Doppler signal is blue, which is away. So it's really important that we identify the portal and hepatic vascular systems sonographically. The porta hepatis, this is super important. That's where the three you can kind of see them all course into the liver together, the bile duct, the hepatic artery, and the portal vein. So the common bile duct is around 4 to 8 millimeters. The hepatic artery is 2 to 6. And color Doppler helps to distinguish between bile duct from the hepatic duct due to the presence of flow in the artery and absence of flow in the bile duct. So you shouldn't see any color Doppler within the bile duct. These are the different sonographic signs between them. Pulsations should only be seen in an artery or vein. They should not be seen in a bile duct. A crossing artery can indent a duct or a vein, but the opposite is not true, because arteries have thicker walls. The artery may not be parallel with the vein or may do so only for a short distance, whereas the ducts are always parallel with the veins. Arteries may be tortuous and loop in and out of the scanning plane, and arteries produce pulsatile Doppler signals, veins produce continuous Doppler signals, and ducts produce no signal. A is the transverse section demonstrating the splenic vein and the portosplenic confluence. B is a oblique section at the long axis of the portal triad, demonstrates the main portal vein, the bile duct, and the hepatic artery. And this is super important. C is an image of the portal triad with the Mickey Mouse sign is what we call it. The main portal vein represents the head, and the bile duct and the hepatic arteries represent the ears. So the bile duct's on the left, the hepatic arteries on the right. To make sure that you're locating them correctly, you can just put color Doppler on, and the bile duct will not show color. So which ligament surrounds the portal triad? Do you guys remember this? If you answered A, you are correct. It's the hepatoduodenal. Which scanning plane is best to visualize the hepatic veins? If you said B, transverse, you were correct. Transverse superior, you're going to see the hepatic veins drain into the IVC. Which universal nomenclature is used for a hepatic lesion localization? If you said C, you are correct. Those are going to be your 8 different sections. Which sonographic sign is reliable to differentiate the bile duct and hepatic artery when evaluating the porta hepatis with the Doppler technique? If you said D, you are correct. Arteries produce pulsatile Doppler signals and ducts produce no signal. The liver is essential to life performing over 500 separate activities. So a single liver cell diverse activities to factory many chemical compounds, warehouse with short and long-term storage capabilities, power plant producing heat, waste disposal plant excreting waste, and scientists are able to regenerate tissue if they're not so severely damaged. There's 3 types of cells that carry out functions. Hepatocyte in the parenchyma is the most abundant cell. Biliary epithelial cells, or Kupffer cells. Hepatic diseases alter these functions and produce identifiable clinical manifestations. So which cell type is most abundant in liver parenchyma and carries out the most metabolic functions? If you said B, hepatocyte, you're correct. A little bit about liver function tests. Liver enzyme normally ends in ACE. Laboratory function tests usually use initials. Alterations in normal liver function tests can produce disorders that can severely impair some functions and leave others unaffected. To understand major tests to evaluate liver function, correlate clinical history, presenting symptoms, and distinguish obstructive and non-obstructive jaundice. If a request only has clinical information of increased liver function tests or LFTs, we want to primarily evaluate for the presence of any dilated biliary ducts. And the presence of dilated biliary ducts means patient may need surgical treatment versus medical treatment if ducts are not dilated. And you will scan a lot of patients that have increased LFTs. What name usually ends in ACE? If you said C, enzymes, you're correct. Okay, so let's get to the good nitty gritty of what we do as ultrasound techs. Sonographic examination techniques. Scanning technique, liver. So our scanning technique, our liver is evaluated in both sagittal and transverse planes. There is some additional oblique scanning places. Planes are used to look at the entire liver parenchyma, ligaments, fissures, vessels, bile ducts evaluated. So you want to pay attention when you're scanning a liver: size, echo texture, size of the intrahepatic vessels, extrahepatic vessels, and IVC, caliber of the bile ducts, pathology affecting hepatobiliary structures. So we have a protocol based on AIUM, which is our American Institute of Ultrasound Medicine. It's kind of in the American College of Radiology. So between those two, they have came up with a protocol of the pictures we need to take. And here they are. This is what you're going to need to know in your lab, and you know, in this class as the pictures that you need to take when you are imaging. So our first picture is going to be of the left liver lobe, the gastroesophageal junction, which is right below the liver. And that's going to be the first picture. It's going to be like way left. Our next picture is going to be the left lobe still, and there's going to be the aorta there. Our next image is the sagittal section through the left lobe and the caudate lobe at the level of the IVC, so that you can see that the ligament venosum right there separates the caudate lobe and the left lobe. Next up is an image of the main lobar fissure, which is this long fissure that separates the left liver lobe from the right liver lobe, and then the gallbladder is right next to it. Then you're going to have a beautiful picture of the entire right lobe of the liver with the right kidney. And then you're going to go to the most lateral part of the right liver lobe. Transverse section, then you'll go to your transverse section through the superior aspect of the liver. Transverse the section through the left lobe, caudate lobe, and ligament venosum. And B. C, you're going to get that really pretty picture of the hepatic veins draining into the IVC. D is a transverse section through the liver at the level of the hepatic veins. Transverse section through the right lobe of the liver with the right portal vein. And transverse section through the inferior aspect of the right lobe of the liver, right kidney, and IVC. We use transducer frequency from 1 to 9 millihertz, the highest frequency transducer to achieve best possible resolution. Focal point is going to be kind of low because you want to see the whole entire liver. curved array transducers, preferably with a wide sector. Want to make sure that your TGC and overall gain is good. So it's not too bright, not too not bright. So there's some scanning pitfalls. Although resolution is improved using harmonics, pay attention to the whole image. Harmonics helps to reduce artifacts, and the single arrow shows loss of echoes in the near field due to elimination of reverberation artifact, and then we don't penetrate the lower portion of the liver with harmonics. B, there's the arrow right there is pointing to the bullseye lesion that casts a faint shadow. This is not a mass. This is a transverse picture of the ligament teres. So you want to make sure that you're not calling this like an echogenic mass. The way that you could tell is you elongate it and turn it in the sagittal view, and you'll see that it turns into a line rather than a circular mass. Rib shadows is a huge scanning pitfall for the liver. And you know what you're going to get into is when you get into lab and you're practicing, you guys are going to, you're young, healthy people. So you're going to be able to see the liver really well. And you won't have to deal with rib shadows as much because you won't have to scan through the ribs. When you get out into the real world, what's going to happen is that you actually have to, people are not healthy, a lot of the times, and you can't see due to body habitus at midline liver. So you're going to have to scan through the ribs, and you're going to have to contend with rib shadows, and you'll get good and better at like navigating through the ribs, but it's hard at first. The gastroesophageal junction is not a mass, so you want to make sure that you know that's normal anatomy. Riedel's lobe is not hepatomegaly, it's just a Riedel's lobe. So which of the following are best documented in a sagittal plane? If you said C, you are correct. Okay, so let's talk about hepatomegaly. It's defined as an enlarged liver beyond normal size. What I want you to know is that a normal liver is less than 15.5 centimeters. So anything larger than that in a sagittal plane is considered enlarged. And it can be due to infection, hepatic tumors, congenital or metabolic disorders. Common reasons for hepatomegaly as diagnosed by sonography include masses, cyst, hepatitis, polycystic liver, non-alcoholic fatty liver, or a Riedel's lobe. So which measurement is stated in the reference to diagnose enlarged liver? Is it due to weight? Is it an AP measurement? Is it a transverse portion, or is it the length of the right surface? So if we just talked about this, so I hope you said D, because it's a length of the right surface that is greater than 15.5. There is hepatocellular disease that we need to know about that causes hepatocyte dysfunction and interferes with normal liver function. It affects the disease process on the whole liver, ranges from simple fatty changes to more severe hepatitis and progressive cirrhosis. So it can be pretty bad. As the disease progresses, liver is generally more difficult to penetrate due to increased down attenuation. So it really, if you have like a fatty liver or a liver that is just getting sick, it's kind of difficult to scan through it because of the liver is grabbing the sound more. Sonography detects diffuse hepatocellular changes. Most common cause of acute liver failure in the United States is an overdose of acetaminophen, usually from a suicide attempt. So fatty infiltration, I feel like fatty infiltration is one of the things that we see quite a bit. Fatty infiltration of the hepatocytes by itself usually does not disrupt physiological processes, but with time, accumulation of fatty triglycerides within the liver cells may cause liver lobules to separate and organs weight increases. So alcohol abuse and obesity are two of the main leading causes of this. There's quite a few other causes too, but those are the two leading causes. Eliminating the process causing fatty metamorphosis may actually reverse the infiltration. So a patient comes in with fatty liver, they're like, you're getting fatty infiltration in your liver, you have elevated LFTs, liver function tests, you need to lose some weight. And so the patient goes, and the patient, like, for 6 months, doesn't drink too much, really works on themselves, loses a substantial amount of weight. There's a really high chance that the liver actually, if it's not to a point of severity where it can't restore itself, the liver is awesome at restoring itself. And so it can actually reverse the infiltration. So I've seen people come back in and their liver looks so much better. Hepatomegaly might be present in fatty infiltrate. So this is what it kind of looks like. A sagittal image using a curved linear array through the right lobe of the kidney demonstrates classic signs of fatty liver, which are heterogeneity. So it just is difficult to scan. It looks more heterogeneous than pretty. Lack of visualization of internal vessels, so you're not seeing your veins and arteries as much in your bile ducts. Marked difference in echogenicity between the liver and kidney, and decreased sound penetration, limiting visualization of the diaphragm. It is so hard to scan through a fatty liver because of this. So I can never really see the posterior portion of the liver as much as I should, no matter what I do. So sometimes a lower frequency sector, you can actually see better if you turn down the frequency quite a bit. Focal fatty infiltration is where the arrows, it looks a little bit more echogenic. And two areas of the focal fatty sparring, which are the arrows, are seen in classic locations as hypoechoic irregular shapes anterior to the gallbladder and portal vein, and that's usually where it's located if there's some fatty stuff hiding in the liver. A glycogen storage disease is autosomal recessive disorder, and defect allows excessive deposits of glycogen to be stored in the liver, intestinal tract, and kidneys. Sonographic features of type 1 marked diffuse increase in parenchymal echogenicity and decreased penetration, indicating a fatty liver, hepatomegaly, and possible solid liver masses. So that's what you're going to see. This is with a patient who has glycogen storage disease with liver cell adenomas. Hepatitis is inflammation of the liver. Key causes are reactions to viruses or toxins such as drugs or alcohol. Viral hepatitis may be mild or extensive. There's quite a few types, type A, B, C, D, and E. Hepatitis A is highly contagious liver infection caused by hepatitis A virus. Hepatitis B is a severe liver infection caused by hepatitis B virus, but it can be preventable by vaccine. Hepatitis C is an infection caused by a virus that attacks the liver and leads to inflammation. And hepatitis D is a serious liver disease caused by infection with the hepatitis D virus. Hepatitis E is by the hepatitis E virus. Alcoholic hepatitis is liver inflammation caused by excessive alcohol consumption. And it goes on and on. Autoimmune hepatitis, inflammation of the liver occurs when the immune system attacks the liver. Yeah, so there's a lot of things that can make your liver inflamed. So when we're looking at a patient with hepatitis, the role in sonography is to evaluate parenchymal changes, document hepatomegaly if present, and exclude biliary obstruction. This is a source of jaundice. Usually when it's acute phase, the parenchymal pattern ranges from normal to hypoechoic, secondary to diffuse swelling of the liver cells. The portal vein walls appear more hyperechoic against hypoechoic background, called star sign. Periportal collagenous markings are easily extending in the peripheral and the liver, and gallbladder wall thickening may be noted. Sorry, I was like, starry star. I was like, starry night sign is what it's called. I was like, what? Okay, so this is a picture of the diffuse like hepatitis. When it's the gain is really down, you can see there's a lot of bright little veins in the liver, and those are the bile ducts called starry night sign. And this is in the same patient figure A with overall gain increase to fill in the liver parenchyma. Right kidney is normal and appears more echogenic than the liver due to decreased echogenicity of the liver. Hepatitis Hepatitis is a transverse image in a patient with acute hepatitis, demonstrating vessels seen as linear bands extending out to the periphery of the liver. And cirrhosis is one of the 3 types of alcoholic liver disease. Other 2 are alcoholic fatty liver and alcoholic hepatitis. It's a general term for a diffuse process that destroys normal liver lobule architecture. And the end result of the chronic and severe damage to liver cells leads to inflammation and necrosis. Liver is the only body organ that can regenerate new healthy tissue if hostile environment is removed. So initial changes cause liver enlargement, but continued insult results in atrophy. So first, the liver is going to get really big, and then it's going to shrink as it gets even more sick. It's kind of crazy how the body does this, but new vascular channels can form collateral shunts if to cause the portal venous blood to bypass the liver because it can't go through the liver correctly. About 50% of all liver cirrhosis deaths is attributable to alcohol. Cirrhosis also develops in course of other disorders such as viral hepatitis, toxic drug and chemical reactions, biliary obstruction, and cardiac disease. And cirrhosis is also associated with metabolic defects and storage diseases that cause minerals to be deposited in the liver. Cirrhosis can take one of 4 forms: alcoholic, biliary, post-necrotic, and metabolic. The LFT's abnormalities depend on the stage and extent of the disease. Sonographic features of cirrhosis vary with disease progression. Early features are going to be hepatomegaly and textural changes. In late disease, there's going to be liver atrophy, especially in the right lobe, caudate lobe hypertrophy, surface nodularity, internal textural changes ranging from fine to coarse, from hypoechoic to hyperechoic, loss of delineation of intrahepatic vasculature, and possible findings related to portal hypotension. So there's secondary findings of cirrhosis past the liver. So the spleen could be enlarge. There could be varices, collaterals, and ascites. I see a lot. Portal vein velocities are often reduced or become hepatofugal. Hepatofugal is away from the liver. Get away from this sick liver, is what the portal blood thinks, I think. Hepatic artery will enlarge and have elevated velocities to maintain hepatic perfusion. Doppler waveforms recorded from hepatic veins demonstrate continuous flow, describes as portalized hepatic flow. Here are all of the possible collaterals. Isn't that crazy? Your body will try to reroute that blood if it needs to. The other thing is you're going to get some ascites, which is fluid around the liver. These are a couple of images of the fluid seen anterior to the liver. This is late stage. See how shrunken the liver is and see how much fluid is around it. So sad. The level of the IVC and large caudate load associated with advanced cirrhosis. Caudate lobe enlargement is thought to be from alterations in portal blood flow to liver secondary to venous compression by fibrosis or regenerative nodules and ascites. And F, you're seeing image of cirrhotic liver demonstrates multiple hypoechoic areas that are compatible with regenerating nodules. And again, that's late stage. This one, a G, that arrow, that little mass right there, was a hepatocellular carcinoma, which can take place in cirrhosis. So not only they get cancer too on top of it. So I is a normal liver capsule, and J, it has mild cirrhosis, the nodularity of the parenchyma, and slight irregularity of the capsule. Here's another picture of it, how it's all jagged. Here's another picture of the hepatic artery, main portal vein. So it's like a corkscrew appearance of the hepatic artery that can occur because of decreased portal venous flow, increased arterial flow, and shrinkage of the liver. You can increase your pulse repetition frequency to reduce aliasing. Color Doppler image here demonstrates reverse flow, hepatofugal flow, and hepatopedal flow of the hepatic artery. In a patient with cirrhosis, transverse image of the spleen demonstrates splenomegaly. And you can see on P, those little sagittal image demonstrates multiple cystic areas superior to the aorta compatible with esophageal varices. So some collaterals there. Another crazy thing that can happen with cirrhosis is that the umbilical vein can recanalize. So it can be like, hey, we got to get blood flow around here. So it can actually open back up. Which is nuts. So if you see that big old collateral there, it decides that it has to get the blood flow somehow, so it just opens back up. All right, let's do our quizzes and then we'll be done for today. Okay, which sonographic feature is a classic sign of fatty liver infiltration? If you said C, it's decreased sound penetration. Which sonographic feature is associated with type 1 glycogen storage disease? If you said A, it's marked diffuse increase in the parenchymal echogenicity, you're correct. Which sign describes the sonographic finding when the portal vein walls appear more hyperechoic against a hypoechoic background of a edematous liver? C, starry sky. What could cause portal venous blood to bypass the liver? B, new vascular channels forming collateral shunts. All right, I think we're good for today. That is a lot of information. So we will continue on next week with it. So just start reading your chapter and go through what we've gone through today, and we'll keep going. I hope you have a good day. Bye-bye.